Well, I'm so glad to be here. And Rob, can you please confirm that you're seeing my slides?
Yes, everything looks good. Thank you, Matt.
Good. All right. Thank you, everyone. I'm Matt Semler. I'm from Vanderbilt University, part of the Pragmatic Critical Care Research Group. And it's a real pleasure for me today to join this Critical Care Review's live stream to present the results of our pragmatic investigation of optimal oxygen targets trial, the PILOT trial. PILOT was funded by the National Heart, Lung, and Blood Institute, and the collection of long-term outcomes, patient-centered outcomes in the PILOT trial was funded by the National Institute on Aging. My portion of today's live stream will present the background, methods, and results of the PILOT trial, and will deliberately defer most of the discussion to Dr. Young as the editorialist and our expert panel to talk about strengths and limitations of the trial and how it fits into the context of prior research. So background for the PILOT trial is that more than 3 million critically ill adults receive invasive mechanical ventilation each year in the United States alone, and that providing mechanical ventilation to a critically ill adult universally involves titrating the fraction of inspired oxygen to maintain an arterial blood oxygen level. And yet, despite millions of patients receiving oxygen during mechanical ventilation in clinical care each year for decades, the oxygenation target that produces the best clinical outcomes for patients has historically not been known. This slide shows the range of our blood arterial oxygen levels that are commonly experienced by mechanically ventilated ICU patients in current clinical care. And that range spans all the way to the right side of this figure, with some patients experiencing these values of 100%, 99% in terms of their arterial oxygen saturation, down to the left side of the figure where patients experience values of 88, 89, 90%. And within this range of values seen in clinical care, there are three basic approaches to oxygen targets. One approach would be to target oxygen values on the lower end of this range seen in clinical care. So values are in the range of 88 to 92%, for instance. Another approach would be an intermediate target where you're shooting for values between 92% and 96%, for instance. And then a third approach would be a higher target, such as values 96 to 100%. And each of those three basic approaches, a lower target, an intermediate target, or a higher oxygen target, has theoretical pros and cons, right? So oxygen targets on the higher end of the range used in clinical care has the potential advantage of avoiding hypoxia, creating a bigger buffer against the development of hypoxemia, but it might have the disadvantage of exposing patients to excess FiO2, hyperoxemia, hyperoxia, each of which might have physiologic downsides. In contrast, targeting oxygen values in the lower end of this range might avoid those risks, excess FiO2, hyperoxemia, hyperoxia, but might have the disadvantage of having a smaller buffer against episodes of hypoxemia and hypoxia. Targeting intermediate oxygen values in between these two could theoretically avoid the risks both of hyperoxia and hypoxia. And there have been observational data that there might be a U-shaped association between blood oxygen levels and outcomes, in which the best outcomes are happening not at higher blood oxygen levels or lower blood oxygen levels, but in some sort of theoretical sweet spot. So that's potential advantage of an intermediate target. But the potential disadvantage is that instead it could be an intermediate target could be intermittently exposing patients to both sets of risks. So sometimes hyperoxia, sometimes hypoxia. And because of the uncertainty about which of these oxygen targets results in the best clinical outcomes, the recommended targets differ significantly between different international guidelines. And recognizing these three potential targets as represented in clinical practice and recommended in different international guidelines, in 2017, we set out to design the PILOT trial with the aim of determining the effect of a lower, intermediate, and higher oxygen target on clinical outcomes for mechanically ventilated critically ill adults. And this emphasizes the first big design choice around the PILOT trial, which was to include 3 trial groups. So each of the prior trials that have come out over the last several years examining oxygen targets in critically ill adults has tended to compare 2 groups, one with a higher oxygen target, one with a relatively lower oxygen target. And if there were a U-shaped relationship in which the best outcomes occurred at a sweet spot somewhere in the middle, comparing two groups, a higher group and a lower group, could theoretically miss that finding. So in setting out to design pilot, one of the big decisions we made early on was to compare a lower, an intermediate, and a higher oxygen target. The second major trial design choice we made going into the pilot trial was to focus on early intervention. We know from observational research that patients' exposure to hyperoxemia and excess FiO2 is greatest in the minutes to hours after the tracheal intubation and initiation of mechanical ventilation. And observational data have suggested that this early exposure to hyperoxia and excess FiO2, even including in the emergency department, even prior to ICU admission, appears to be associated with worse outcomes among critically ill patients. And so we found, in designing the pilot trial, we thought it was really important that the pilot trial enroll patients essentially on the initiation of mechanical ventilation, so that, including in the emergency department prior to ICU admission, so patients weren't receiving mechanical ventilation and these high levels of FiO2 and SpO2 in all groups of the study prior to it. And the third trial design choice for the pilot trial was to focus on targeting SpO2. So SpO2 and PaO2 are two targets, two ways of assessing oxygenation, and different trials some have targeted SpO2, some have targeted PaO2. Our rationale for targeting SpO2, which is this oxygen saturation as measured by continuous pulse oximetry, is that it's a value that's available essentially continuously to titrate the fraction of inspired oxygen throughout critical illness. So in our clinical setting, where the trial was performed, we looked at observational data, and an arterial blood gas PaO2 measurement occurred in less than 1 in 4 patients on any given study day, whereas the SpO2 values we were able to download directly from the bedside monitor every 1 minute. So thousands upon thousands of values for every individual patient to much better categorize and capture episodes of hypoxemia and other things that were critical to the trial. So those are 3 major design choices we took into the pilot trial. And we designed pilot as a pragmatic, unblinded, cluster randomized, cluster crossover trial, and we'll talk more about that in a minute, for which enrollment began on July 1st, 2018, was paused for 2 months during the first wave of the COVID-19 pandemic, and concluded on August 31st, 2020. The pilot trial was conducted in the emergency department and medical intensive care unit at Vanderbilt, and all adults in the medical ICU or in the ED with planned medical ICU admission were enrolled at the time of the first receipt of invasive mechanical ventilation, except those who were less than 18 years of age, pregnant, or in prison. So we talked about that cluster level design. So this pilot was designed as cluster level randomization. So all patients in the ED and ICU were assigned together to a single SpO2 target, and then cluster level crossover. So every 2 months, the ED and ICU switch together between SpO2 targets in a sequence generated by computer randomization using permuted blocks of 3 to minimize the effects of seasonal variation. So if you look down at the figure, what that would mean, start of the trial in 2018, that first 2-month block is assigned to a higher target. The whole environment that crosses over in the second 2-month block to an intermediate target, to a lower target, to an intermediate target, to a lower target, to a higher target, to a lower target, and so forth throughout the duration of 36 months of the trial. The last 7 days of each of these 2-month periods were included as an analytic washout period. So the study in ED and ICU continued to use the assigned target. The patients who were enrolled during this 7-day period were not included in the primary analysis. They were included in other secondary analysis, but not in the primary analysis. So why cluster level allocation? What was the rationale? This had 2 focuses, one of which was to emulate the way oxygen targets are managed in clinical care in this environment. So prior to designing the trial, we looked at how are oxygen targets administered in clinical care in these environments. And like tidal volume, PEEP, spontaneous awakening trials, spontaneous breathing trials, oxygen targets in these environments were administered through unit-wide protocols in which a small number of respiratory therapists would administer these protocols to all of the patients in a given unit. So in clinical care prior to these trials, these are cluster level protocols. They're every patient in the location, small number of providers for a large number of patients. And so we adhered to that structure for the conduct of the trial. The second rationale for cluster level allocation was that because group assignment is known at the moment of eligibility, it permits enrollment and immediate intervention at the point of initiation of mechanical ventilation. So the ability to have the first mechanically ventilated breath, even in the ED, be compliant with study group assignment, minimizes pre-study exposure to excess FiO2, hyperoxemia, and hyperoxia, and facilitates on-study separation between groups during that really critical early period. So similar to prior trials of oxygen targets during critical illness, patients were enrolled under a waiver of informed consent, and that has two components that are worth considering. So one of which is that this was considered minimal risk because it compared three approaches that lay within what was common in clinical care. And the trial determined oxygen targets only for patients for whom clinicians were uncertain of which target would be best and felt all three were reasonable. So if a condition developed that a clinician felt the optimal oxygen target was known for a given patient, for instance, the patient developed an pneumothorax and had to receive 100% FiO2, that target was used and the reason for that was modified. So trial protocol was only controlling oxygen targets in instances where clinicians acknowledged that they didn't know which of the three would be best for that patient. Second, because all of these patients were unconscious at the time of enrollment, it was impractical to obtain written informed consent from every patient in ED and ICU prior to emergency tracheal intubation and initiation of mechanical ventilation. So patients were initially enrolled under waiver. Patients and families were notified of participation with an IRB-approved information sheet, and then patients or their legally authorized representatives were approached for informed consent for follow-up and assessment of long-term outcomes as part of the independently funded co-pilot study, the results of which those outcomes have just now finished being collected. The intervention in the pilot trial was delivered by clinical respiratory therapists who titrated the FiO2 to achieve the goal SpO2, beginning in at least within 15 minutes, often sooner, of initiation of mechanical ventilation and ending at discontinuation of mechanical ventilation or transfer out of the study ICU. Trial protocol did not determine the SpO2 targets during transport outside the unit, during procedures, or while the patient was undergoing spontaneous breathing trials. The table here shows the targets for each of the three groups. So in the lower oxygen target group, the target was 90%. The range was 88 to 92%. In the intermediate target group, the target was 94%, and the range was 92 to 96%. And in the higher target group, the target was 98%, and the range was 96 to 100%. In instances in which plethysmography was inadequate or SpO2 monitoring was unavailable or felt to be inaccurate for a given patient, clinicians were provided these PaO2 targets and ranges that they could use at any point instead of the assigned SpO2 target when clinically appropriate. As I mentioned earlier, at any time during the trial, if a clinician, patient, or family member determined that an oxygenation target other than the target assigned by the trial would be best for the care of that patient, that other target was used, and the reason for that change was recorded on a SpO2 modification sheet. And institutional protocols and treating clinicians determined all other aspects of mechanical ventilation besides oxygen target, tidal volume, PEEP, analgesia, sedation, timing of SATs and SBTs. Data for the trial were collected by study personnel from the electronic health record on baseline characteristics, on-study management, and hospital outcomes. And data on SpO2, FiO2, and ventilator settings were automatically extracted from the bedside monitor into the trial database with a frequency of every 1 minute. So over the course of the trial, about 8 million SpO2 values or several thousand, more than 1,000 per patient were collected. Primary outcome of the trial, ventilator-free days, the number of days alive free of mechanical ventilation through study day 28. The sole pre-specified secondary outcome of the trial was in-hospital mortality, defined as death from any cause prior to day 28, censored at hospital discharge. And you can see here listed the exploratory clinical organ function and safety outcomes that were pre-specified and collected. Over the planned 36 months of enrollment, we anticipated that 2,250 patients would be enrolled, and the number of ventilator-free days would have a median of 22, interquartile range of 0 to 25, and that the intra-cluster, intra-period correlation would be 0.01. That is to say that patients in one 2-month block would not be very dissimilar from patients in the next 2-month block. This correlation is a measure of how much the patients are more similar within their period compared to patients in other periods. With an alpha of 0.05, we calculated that we have 92% statistical power to detect a difference of 2 ventilator-free days between any 2 of the 3 trial groups. And so this difference of 2 ventilator-free days is a magnitude that was considered to be clinically meaningful in the FACT trial and in other critical care trials. Primary analysis population included all patients enrolled in the trial except those admitted during one of the pre-specified 7-day washout periods who were not included in the primary analysis but included in other analyses, and patients with laboratory confirmed COVID-19. So patients with COVID-19 were not included in the primary analysis because the majority of the trial occurred before the pandemic, and patients with COVID-19 were cared for in a separate COVID ICU, not participating in the trial. So they're included in other sensitivity analyses, but not in the primary analysis population. Primary analysis used a proportional odds model with the dependent variable of the primary outcome of ventilator-free days and independent variables of group, so lower, intermediate, higher SpO2 target group, and then time, which was a measure of days from the start of enrollment to the enrollment of that patient. And sensitivity analyses examined the analysis of the primary outcome with different statistical techniques, including generalized estimating equations accounting for period, analyses accounting for seasonality, analyses accounting for pre-specified baseline covariates, and then subgroup analysis. So over the 36 months of the pilot trial, 3,024 critically ill patients received invasive mechanical ventilation and were screened for eligibility, of whom 37 were excluded, 2,987 were enrolled and randomized, and that primary analysis population included 2,541 patients. The baseline characteristics of those 2,541 patients are shown here by trial group. And the key baseline characteristics that I think are worth highlighting include this median time from initiation of mechanical ventilation to enrollment. So for that time was a median of 0 hours. And so for the majority of patients in the trial, their FiO2 and their SpO2 target would begin at the first receipt of invasive mechanical ventilation. And for a third of patients, that was in the emergency department. The other 2/3 were enrolled in the intensive care unit. And you can see that the coexisting conditions, acute illnesses, were similar between groups, as was the severity of illness at baseline. So shown here is the separation between groups in the SpO2. So the x-axis is days since enrollment. The y-axis is patients' SpO2 values. And you can see that SpO2 values are lower in the lower target group compared to the intermediate or higher target groups, and that separation occurs almost immediately. Right? So actually, if you compare the first value 1 minute after tracheal intubation for SpO2 and FiO2, there's statistically different between groups. So a very early intervention facilitated by the cluster level group assignment. What did that translate into? So patients had almost 8 million SpO2 values in the trial data set. And for patients in the higher group, about a third of all values were either 99% or 100%. Patients in the lower target group, only 6% of those values were in that range. And conversely, there were no differences in values that were low. So values of SpO2 less than 85% less than 80%, less than 70%, and no measure of severity of hypoxemia were there differences between the three trial groups. Separation between groups in the fraction of inspired oxygen. So this is days again on the x-axis, FiO2 on the y-axis. And you can see that the fraction of inspired oxygen received in the lower target group was lower than in the intermediate or higher target groups, beginning within minutes of the initiation of mechanical ventilation. And what that translated to, 8 million FiO2 values. Of those, almost 70% in the higher target group were more than an FiO2 of 0.4, whereas just a third were in the lower target group. And in terms of the proportion of patients or FiO2 values that were 0.21, so ambient air, no supplemental oxygen, more than a third of the FiO2 values in the lower target group were ambient oxygen compared to just 4% in the higher target group. So with that, among those 2,541 mechanically ventilated critically ill patients, with that separation between groups in the SpO2 and FiO2 received, what was the primary outcome like in the three groups? Did it show a difference in the primary outcome? So this is the data on the primary outcome of ventilator-free days. And we found no evidence of a difference between groups in ventilator-free days. The median number of ventilator-free days was 20 with an interquartile range of 0 to 25 in the lower target group. It was 21 with an interquartile range of 0 to 25 in the intermediate target group, and it was 21 with an interquartile range of 0 to 26 in the higher target group. So nothing to suggest a difference in our primary outcome of the number of days alive and free of mechanical ventilation. This is study day 28. When we examined that primary outcome, each of the pre-specified subgroups, we did not see evidence of interaction. There was not any of the pre-specified subgroups in which the treatment group assignment appeared to alter the primary outcome of ventilator-free days. So these are those subgroups shown here: cardiac arrest, myocardial infarction, acute respiratory distress syndrome, sepsis, or septic shock, receipt of a vasopressor at the time of enrollment, and then some additional subgroups from the supplement of the paper: no difference by race, source of ICU admission, receipt of supplemental oxygen prior to hospital admission, coronary disease, or any other of the pre-specified subgroups. We saw no differences in the secondary outcome of in-hospital mortality between the three trial groups, and we saw no differences in the exploratory outcomes, such as the development of acute kidney injury, or the number of days alive and free of vasopressors, the intensive care unit, or the hospital. We saw observed no differences in each of the safety outcomes that we measured, which included cardiac arrest, arrhythmia, myocardial infarction, stroke, and pneumothorax. So with those background methods and results, I'm going to just present one slide, trying to put this in the context of the prior trials, and then I'll turn it over for discussion to our editorialists and then panel. So in thinking about where does the pilot trial stand, how does it add to and compare to the prior existing trials? So I think the number of mechanically ventilated patients in the pilot trial of 2,541, similar to or larger than each of the prior trials. Time to enrollment. So in pilot, patients began the trial intervention at the initiation of mechanical ventilation, often in the ED or immediately upon receipt in the ICU, so trying to capture even the earliest period of mechanical ventilation for critical illness. The separation between groups in SpO2 values and FiO2 that was achieved in pilot was comparable to or greater than in many prior trials. And the severity of illness in pilot, as gauged by the mortality by day 28, was comparable to many of the prior trials. I think maybe most importantly, this absence of a difference between groups in ventilator-free days or mortality was similar to the results of three large recent trials. So the HOT ICU, ICU ROCKS, and O2 ICU trials had a similar absence of a clear difference in mortality or ventilator-free days between the different oxygenation targets. So to summarize, findings of the pilot trial among mechanically ventilated critically ill adults in this randomized trial, the number of ventilator-free days and incidence of mortality did not differ between use of a lower, intermediate, or higher SpO2 target, and there were no differences in any subgroup or any secondary or exploratory outcome. So as we round the half hour here, this manuscript should be available for you all to review at the New England Journal's website. I want to take this as a moment to thank all of the people who contributed to this, and in particular, the respiratory therapists who are listed here as co-authors and those who weren't, who accepted this into the incorporation of their protocols, and without whom the pilot trial would not have been possible. So I thank all of them for their time and all of our collaborators. And I thank our editorialists and expert panel and all of you for listening, and I look forward to the discussion.
Matt, congratulations. Absolutely fantastic trial. That is very, very impressive. My thanks also to our colleagues at the New England Journal of Medicine and Darren Tackman for facilitating the publication of the manuscript. It should be out in just a couple of minutes. We'll cross now to Wellington and Paul Young to hear his thoughts. Paul.
So thanks very much, everyone. It's a real pleasure to be here. My name's Paul. I'm an intensive care specialist from Wellington Hospital in New Zealand and the Deputy Director of the Medical Research Institute of New Zealand. And I'm really grateful for the opportunity to present the editorial on this fantastic trial. Congratulations to Matt and to his entire team, and I guess also congratulations to Matt for a really clear presentation of the results. I guess my job is to try and let you know what I think about this trial and what it means for clinical practice. So here we go. To begin with, you've already heard that I'm involved in this ongoing trial called MEGAROX, and I was also the chief investigator on the ICU ROX trial. And so on the one hand, while these things mean I do know the literature in this area pretty well, I acknowledge and I declare that I have an academic conflict of interest, which may well impact my ability to provide an unbiased assessment of what this trial means. Indeed, my interpretation may well reflect my biases in ways which I'm not conscious of, and I'd encourage you to keep this in mind when you listen to the things that I say. I would say at this point that there are some beliefs that I hold in relation to oxygen therapy and critical illness that I am conscious of. I believe that large treatment effects attributable to oxygen therapy regimens in critically ill adults are very unlikely. I also believe that small treatment effects that are attributable to oxygen therapy regimens are both biologically plausible and potentially clinically important. And finally, I believe that heterogeneity of treatment effect in relation to oxygen therapy, that the optimal regimen for one group of patients or for one patient might not be the same as the optimal group for another, is an important consideration too. So my interpretation of these trial findings do reflect these beliefs, I guess. So as you probably know, this is one of a series of randomized controlled trials evaluating oxygen therapy in ICU patients specifically. These include the Oxygen ICU trial, which was a single-center randomized controlled trial in Italy that evaluated conservative versus liberal oxygen therapy in the intensive care unit in patients who were expected to stay in the ICU for at least 72 hours, and which reported lower mortality in the conservative oxygen therapy group. Next is the LOCO-2 trial, which was a trial from France, which evaluated conservative versus liberal oxygen therapy in patients with ARDS. and was stopped early because of concerns about harm in the conservative oxygen therapy group. Next, the ICU ROCKS trial, which I mentioned is a trial that I was involved in, evaluating conservative versus liberal oxygen and mechanically ventilated adults in the ICU. The HOT ICU trial, which looked at hypoxic respiratory failure. The Oxygen ICU trial, which looked at patients with systemic inflammatory response. And most recently, the BOX trial, which looked at hypoxic ischemic encephalopathy. And you know, maybe these last group of trials favour a position of equipoise, but in relation to the BOX trial, I thought, you know, that there's a mortality point estimate favouring conservative oxygen therapy, and maybe sort of still a signal there that that may be the best approach for patients with cardiac arrest. So, I mean, I guess the totality of this body of evidence for me does, as I already said, make very large treatment effects from conservative oxygen therapy unlikely. But I think it's also notable that the view that slightly liberal oxygen is bad has become quite widely held. And so this is the context in which the pilot trial was conducted. Okay. So as you've heard already, pilot was a randomized clinical trial. However, unlike a standard randomized clinical trial like this, in which patients were the unit of randomization, here the unit of randomization was the intensive care unit. Now, if there were lots of intensive care units and only 2 arms, then the design would look like this. So you'd have a bunch of intensive care units that would be randomized to treatment A, and then they would swap over to treatment B, or they'd start with B and then they'd swap over to A. However, in the pilot trial, instead of the usual 2 treatment groups, there were 3 treatment groups, and there was only 1 intensive care unit, not many. So to summarize the design in one slide, this is a 3-arm cluster, multiple crossover trial in a single center in the United States of America. This is the schematic diagram from the supplement that shows what happened. And you can see that there's one treatment period where recruitment was halted because of COVID-19. And there's a critical point that I'd like to emphasize about this study design. I won't really dwell on the statistics, but I will try to emphasize the concepts, which is in each of these treatment periods where the ICU is allocated to either A, B, or C, there will be some noise. Or to put it another way, there will be some natural variation in the occurrence of the outcomes of interest over time. Now, if the amount of noise that occurs in the various study treatment periods is identical, then the crossovers mean that the noise is cancelled out in the analysis and all that you are left with is signal. And so if the noise balances perfectly, then a cluster crossover trial basically provides you with the same amount of power as an individual patient randomized controlled trial. Now, another sort of important principle is that more crossovers generally means more power. However, the power that you get with increasing the number of crossovers progressively reduces, or the incremental increase in power progressively reduces as the number of crossovers increases. And so changing from 1 crossover to 2 crossovers makes a really big difference. Changing from 2 crossovers to 3 crossovers makes a lesser but still big difference. But changing from 99 crossovers to 100 crossovers makes virtually no difference at all. And so there's a trade-off in the design of a trial like this in determining the optimal number of crossovers between power and logistics and convenience, because managing the crossovers is labor intensive. You know, you have to have a whole program of making sure that everyone gets on board with understanding what the new intervention that you've moved to is and that you're doing it right. So here's another important point. In general terms, patients admitted to a single intensive care unit in different treatment periods will be more like each other than patients admitted to different intensive care units. And so this is a potential advantage of only having one site. The amount of noise that I mentioned in each period is much more likely to cancel out if you're comparing periods that occurred in the same intensive care than if you're comparing periods that occurred in a different intensive care. So this is an advantage of a single centre participating in a crossover trial like this. Of course, the major disadvantage is that there's only one intensive care, and so that reduces the generalizability of the results, and that's something that we'll talk about a little bit more later. Another thing that's worth noting in this particular study is that there is a non-random influence going on in what the patients in different periods look like. Now, that non-random influence is that, big evil virus at the top of the slide, COVID-19. It's really very unlikely that the case mix of the patients admitted to this intensive care unit before COVID and after COVID was the same. So it's quite likely that after the arrival of COVID, even although COVID patients were being cared for in a different intensive care unit, the case mix was different. Now, because there are multiple study periods of treatment of A, B, and C, both before and after the advent of COVID, this is probably not a major problem, but it is worth considering. Now, it's partly accounted for in the various analyses that have been conducted, but it's not possible to be completely certain that it's entirely accounted for, because it's still possible that there are non-random imbalances in patient characteristics between periods that are unmeasured and therefore not possible to account for. So I don't think that's a major problem, but it is a thing to bear in mind and consider when you look at these data in this trial. So a major strength of a cluster crossover trial is that essentially it eliminates selection bias. For oxygen, a ubiquitous therapy for mechanically ventilated patients, you're studying all the patients who receive the intervention in the real world. Now, the other thing that's really great about this is if the intensive care unit is randomized, then clinicians don't need to remember to enroll the patients. And this makes it relatively easy to conduct a large trial in a short space of time. Conducting a 2,500 plus patient trial in a single intensive care unit is an incredible achievement that probably would not be possible with any other design. And in a sense, I guess the trade-off that's made in this design is that although you've got a major logistic advantage in terms of recruitment, you also have a potential weakness because you've forced enrollment of some patients who self-evidently have no potential to benefit from the treatment being studied. And I'll talk a little bit more about this in detail later on. So because this is a single center trial, a really important thing for clinicians to do is to look at the types of patients in the trial and ask, are these the kind of patients who I treat? Now, when I looked at the baseline characteristics, there were some things that I noticed that are quite different from where I practice intensive care medicine. So first of all, there are no surgical patients. This is a medical intensive care unit. Almost 20% of the patients had COPD, 14% were on home oxygen, 13% were post-cardiac arrest, a third had sepsis or septic shock, and remarkably for me, a third of these patients, 3% of these patients, the indication for invasive mechanical ventilation was chronic mechanical ventilation. So where I work, chronic mechanical ventilation is not a thing. There is not a single patient in the entire centre of New Zealand who has chronic mechanical ventilation. And in our last 2,000 intensive care admissions, I had a look, we haven't admitted a single patient who was on home oxygen to receive invasive mechanical ventilation. So this means that, for me at least, there is a risk that the results of this trial are not generalizable to my setting. I guess in relation to that last point of chronic mechanical ventilation, this is a good example of a group of patients being forced into enrolment who don't have potential to benefit, because presumably patients who are chronically mechanically ventilated all end up with 0 ventilator-free days because they were ventilated before the intensive care admission, so they can't achieve the primary outcome. Okay, now the next element of the trial that I think is important to look at is what was intended. So this is what the intervention was, these study treatments were supposed to be, a target of 90, 94, and 98 respectively. And this is what actually happened. So here I think it's really important to emphasize the strength of the study in comparison to any previous study. The amount of granular detail in relation to oxygen exposure was far greater than in any previous clinical trial, but the groups didn't end up getting exactly what was intended. So the 90% target ends up around 93 to 94. The 94% target group ended up around 95, and the 98% target group ended up around 97. That's not a big problem. You know, there's clear important separation between groups. It's just an interesting observation that what was intended is not exactly what occurred. So the primary endpoint was ventilator-free days through to day 28, and having more ventilator-free days is a better outcome. Patients who died before day 28 were considered to have 0 ventilator-free days. And so, in a sense, ventilator-free days is a composite endpoint that combines 28-day in-hospital mortality with the duration of mechanical ventilation for survivors. Ventilator-free days has good points and it has bad points as an outcome. It offers more discrimination between patients than mortality by ranking survivors in a way that has face validity. So for people who live, less time on a ventilator seems good. And not only that, but it also seems possible that the oxygen therapy regimen might affect the duration of mechanical ventilation, either by altering the clinician's behavior or by altering the pulmonary physiology, or potentially by doing both. But there are some things about ventilator-free days which are not ideal. So ventilator-free days ranks dead people and people who are ventilated for 28 days or more as having the same outcome, and that's probably not reasonable. As I've said, among people on chronic ventilation, this is not a useful outcome because presumably 100% of those people end up with 0. One way of overcoming the problem of patients being ventilated for 28 days or more having the same outcome of death is to actually assign a different outcome. So you can rank dead patients with a rank of -1 to make them have a worse outcome. It's very unlikely that doing that here is going to have made a difference to the conclusions that you would draw, but that's just a point to make methodologically. So another thing that's really troublesome about ventilator-free days, and this is something I've thought a little bit about, is that because ventilator-free days combines 28-day duration of mechanical ventilation among survivors and mortality into a single number, it's really difficult to understand intuitively what a difference of 2 ventilator-free days actually means. Because that can be achieved in different ways by changing either component of the composite, but it isn't really at all obvious what that difference actually means and what the magnitude of the difference means. Okay, so in this trial, the precision of treatment estimates in relation to ventilator-free days for one category versus another is expressed as an odds ratio. And so these are calculated by treating ventilator-free days as a categorical variable. That's dividing it into 29 categories from 0 up to 28, and then working out what the odds are in each category of having each for each treatment. That gives you an odds ratio, which you then summarize across all the categories into a single number. And so that's really quite tricky to understand, right? Because it's a summary of odds across 29 categories turned into a single number. But it is lucky that if you compare high versus intermediate, you get an odds ratio of 1.00, which means the best estimate is that high and intermediate oxygen gives you the same number of ventilator-free days. The comparison for high versus low gives you an odds ratio of 0.95, which suggests that high might be better than low. Now, the potential range of potential effects encompassed by the 95% confidence intervals is broad and probably actually encompasses, in my mind, what would be a plausible clinical difference. But it is very hard to conceptualize and understand what the range of odds ratios actually means. Overall, though, I think the primary outcome is consistent with all of the most methodologically rigorous trials. And the best estimate from these trials is that the oxygen regimens do not dramatically affect the patient outcomes. Now, I think that the systematic evaluation of high, intermediate, and low is a really important knowledge advance compared to previous trials. These are the 28-day in-hospital mortality estimates. And, you know, the confidence intervals surrounding these estimates are very large and certainly encompass clinically important effects. But like other recent trials, they do provide reassurance that large mortality effects attributable to oxygen therapy in this group of patients are unlikely. A really useful advance from this trial is that the high normal range did not appear overtly harmful. And this is the finding which, in my mind, challenges a recent dogma, I guess. In fact, I think that the estimate in favor of high normal, here that is the mortality is lowest in that group, is really interesting and potentially important. One other thing that I think is that, you know, for my mind, and others may not agree with me, but I think that over the range of subgroups that are evaluated, the power to detect plausible heterogeneity in treatment effect is probably very, very low. So I don't think that we can really rule that out. I would say, though, that if you look at this difference between highest and lowest mortality, that was highest and lowest oxygen, that was 1.6 percentage points. And for a ubiquitous therapy like oxygen, a small effect like this has the potential to have global public health importance. In the introduction, Matt said that there are more than 3 million people critically ill who are ventilated in the United States of America alone. If liberal oxygen therapy truly did reduce mortality by 1.6 percentage points, then we would be looking at saving in excess of 50,000 patients per year in the United States alone by implementing this intervention. So here are a few closing thoughts from me. First, I think that it's likely that we're going to see more trials with the design like this. And this trial is remarkable for showing that even one intensive care unit committed to advancing knowledge can really achieve pretty remarkable things with a design like this. The results certainly apply in that intensive care unit. But for me, the patients in this study were quite different to the patients that I look after. As I declared to begin with, I consider large treatment effects to be quite small, and really this study neither confirms nor refutes effects of a magnitude that I believe are plausible. And I also consider that it's unable to confirm or refute heterogeneity of treatment effect. It just doesn't have power to detect the kind of heterogeneity of treatment effect that I think is realistic. And the second line from the top there, you can see, is probably in a way the most important take-home message for me. It's really reassuring to see that there's no overt harm from a slightly liberal oxygen regimen. This is a summary slide of the MEGAROX trial, a 40,000 patient clinical trial in oxygen therapy that is well underway. It's interesting to see that if the effect that was shown in the pilot trial is the true effect, then the MEGAROX trial will have the ability to show that difference, and we would expect the findings to be statistically significant in favour of our liberal oxygen regimen. So I'm very much looking forward to the discussion, and congratulations to the investigators on adding a really important piece to the puzzle, and to really challenging dogma, and particularly, I guess, in relation to the more liberal oxygen therapy.
Fantastic, Paul. Thank you very much. That was a wonderful editorial. Some really, really interesting points you've made there. We'll go back to Matt. Matt, we're a little bit behind time, so if you could briefly just answer some of the points that Paul has raised.
Yeah, I'm happy to, and I could probably keep it very brief by just saying I agree, but I'll add 2 or 3 more sentences. I think Paul emphasizes that for an intervention that is universally received, right, the most common intervention probably in hospitalized patients is the provision of oxygen, that large effects are unlikely, small effects are meaningful. So I think we probably in critical care are seeing the advent of 2 stages of research, where there's a first set of trials of 1,000 or 2,000 patients that we had previously thought of as the definitive trials. They can rule out a 5% or a 7% mortality difference. And but if you have a treatment received by millions of patients a year, 1%, 2% are meaningful mortality differences that translate into a lot of lives saved. So I think a major question is, how do we get beyond our current framework for trials that are able to rule out big differences on average and get to trials with sample sizes that can rule out or evaluate little differences? And the second half of that is the emphasis on heterogeneity of treatment effect, which I think is right. I would just frame that heterogeneity of treatment effect begins with treatment effect, and trials are the way to know if there's treatment effect. So the idea that different patients might have different responses to therapy is not an argument against clinical trials, is an argument in favor of clinical trials that are designed with the size and statistical design to estimate treatment effects, ideally, eventually, for individual patients based on their individual characteristics. But we have to get to the size of trials that can do that and statistical methods that can do that reproducibly. So I think I agree with all those. I think for those who are interested in the statistics of crossover trials, I think they've been conflated for a long time with cluster trials. And Andrew Forbes has a series of nice papers that are worth reading about what happens when you increase the number of crossovers and how quickly you can look statistically like an individual patient level trial. So I think I would say that we should be designing trials to emulate the way that those interventions are delivered in clinical care, and then figure out the statistical pieces to match that, not the other way around. I think I agree with all of the points. Our focus within the framework of what we think of as a learning healthcare system, we see it as a mandate to look at the therapies that are being given to our patients day in and day out, and be certain in our health system that we're giving the right therapies that are producing the best outcomes. And that has that focus on evaluation with that local focus, I think, is a clear limit on generalizability in some cases. So I think toggling that ability, we can now be very certain in our health system about what the effects of oxygen are for our patients, but it definitely hinders the ability to translate into other settings where patients aren't managed similarly. I think on the COVID-19 pandemic, table S21 of the supplement, which is long, has a lot of information just on what did the trial look like before COVID existed. Unfortunately, the odds ratios and everything look pretty comparable in that period. And then the last thing I'll say is that I think, unlike a trial in which you have treatment A versus treatment B that patients just receive once and are done with, understanding what you should expect about separation between groups in a target trial is a really interesting challenge. That's true about oxygen targets or blood pressure targets or any other target in critical illness. And in a target trial, patients probably shouldn't be reaching the target, right? And so an example of that here is that a patient who has a SAT of 97% in the lower target group, but who's on room air, you would expect to be that's not non-compliance, that's the protocol being followed. And so it's very difficult to try and present. So the supplement is chock full of examples of us trying to explain that compliance was good and patients were appropriately above the target in the lower group or appropriately below the target in the upper group. And I think taking that framework when looking at any trial of a target is something this has inspired me to do. So I'll leave it there and open it up for the discussion.
Thanks, Matt. We'll turn to Chris, not my colleague now. Chris has questions from the chat function and from Twitter. Chris.
Thanks, Rob. Matt, Derek Russell has congratulated you on a beautiful trial and commented on a nice, clear separation between groups. But I suppose one of the questions that has popped up is, you didn't quite get the separation between the low, medium, and high oxygen levels. So was the separation enough to show a difference in the trial?
Yeah, that's a great question. That's piggybacking on what we were just talking about. Let me, I wonder, I'm going to see if I can briefly show the supplement here. So just to emphasize this point, so you all can now see this figure, is that right? So this figure, supplemental figure S4, shows every one of the 8 million SpO2 values in each of the three groups, where the x-axis is that range of oxygen targets in clinical care, the y-axis is the proportion of SpO2 values at that value. So in the higher target group in red, fewer at 90%, intermediate and lower target group. And the point of showing this is that this is all SpO2 values. And then when you pull out the SpO2 values that are on room air or on 100%, all of a sudden the compliance looks better and different. So I think one of the questions is, when you're thinking about separation between groups in a trial like this, what proportion of it is due to non-compliance, somebody just wasn't following the protocol, and what proportion of it is due to it not being modifiable? That is to say, you followed the protocol as well as you could have in clinical care, but a patient on room air, you're not going to put on hypobaric oxygen to lower to the target, right? There's nothing further you can do. And so I think I would make the argument, and I will hear from our panelists, that the separation between groups in this trial as measured by SpO2 and FiO2 is in the range of at least as good as the prior trials. And I think that's about as good as we're going to be able to do for this question. I'd hear from others.
I mean, I totally agree. Like I was not meaning it as a criticism at all of the design. It's just interesting that the number ends up being slightly different to what was intended, but actually the separation between the three groups in my mind is remarkable. I mean, it's better than any of the other trials, I think. I mean, the precision of the SPO2, the richness of the data and the certainty that you can have about the compliance is far better than for any other trial. That's my take.
Matt, is there a reluctance to aim for a lower SPO2 and with the risk of undue harm from aiming for a number just?
Yeah, so that's a great question. I hear from the panelists on that. My answer, in preparation from this work, our group in the United States, but also groups focused on this question in the Netherlands and other places, did survey work evaluating what was clinical care like, what of these ranges were reflected in clinical care. And our whole effort in the design of the pilot trial was to look at the reasonable options that were within current clinical care and not to examine anything beyond that. So I think there are those who might be interested in whether even lower oxygen targets, or in some instances, deliberate hyperoxemia, what the effects of those interventions are. And in pilot, we had exactly no interest in either of those. That was not what we intended to study. So I think I'd hear from the others about that, but I think I can't make clear enough. Pilot didn't answer any of those questions.
Thanks, Matt. There's a few questions then sort of about exposure or length of time of exposure to the intervention. So you pointed out that the trial was conducted during mechanical ventilation. Any comments on exposure to oxygen prior to ventilation? And then subsequently, I think around 40% of patients were extubated within a couple of days. So was that a long enough period with the intervention to show a difference, or?
So that's a great point, that it is highlighting that you have intervention before enrollment, you have the intervention, which is the separation between groups during the study period, and then the duration of the study period, all of which determine the effective separation between groups. So I think our trial did not control oxygen administration prior to mechanical ventilation. Because patients were enrolled in the emergency department and shortly after ICU admission, that was largely supplemental oxygen by nasal cannula in EMS or briefly in the emergency department. So I think the exposure prior was limited as much as I think we could have by early enrollment. I think that there's a legitimate question of, is the subgroup of patients for whom this intervention might have an effect on outcomes the group for whom their duration of mechanical ventilation is longer and they're likely to be exposed to more excess FiO2, those sorts of things. So I think the way we intended to address that in this trial was to develop a model that used baseline characteristics to tell us who were the patients who were likely to be ventilated for an expected duration of more than 3 days or 4 days. And we spent a year trying to develop that model and cannot accurately predict at baseline when somebody's just been intubated how long they're going to be on the ventilator, although certainly clinicians have some judgment about that. So I think we didn't address that. I think it's possible that the one of the subgrouping variables where there might be greater effect is in patients who would be expected to have more exposure to the interventions.
Thanks, Matt. And of course, the other thing affecting saturations and oxygen levels are PEEP. And can you just, the PEEP levels across the groups seem to be very similar, but the patients were on very different oxygen strategies and inhaled oxygen concentrations. Do you have any comments on that?
Yeah, that's a great question. I think one of the things we were worried about, and one of the things you've seen hints of in different trials of oxygen targets, is that because the titration of PEEP may be linked to P-DEF ratio or partial pressure of oxygen values, that we might see differences between the 3 trial groups and the PEEP that was administered. I think we didn't see that. We had fairly similar PEEP levels in all 3 groups, which were fairly low, I think, compared to some practice settings. But I know that other trials have seen differences in PEEP when the intent was to just target oxygen, but PEEP is one of the tools in addition to FiO2 that can target that. So I think our goal was, we really encouraged people. This was a trial of using the fraction of inspired oxygen to achieve the oxygen target. We were intentionally trying to stay away from PEEP, spontaneous awakening trials, breathing trials, all of those co-interventions. So I think we emphasized that to providers, but otherwise I think we had the same concern that it might affect PEEP, and we just didn't see that.
Yeah. And you had similar levels of PEEP, and you had groups of patients that were on someone on lower amounts of oxygen. And in my mind, as a clinician, when I'm looking at patients who are on low PEEP and low oxygen, I'm thinking, get them off a ventilator, do a spontaneous breathing trial. And you'd expect then that if you had patients on lower amounts of oxygen, that they would get off a ventilator more quickly. But you modified your criteria for spontaneous breathing trials in this. Would that be fair to say?
Yes, your question is a good one, and you could frame that two ways. One of which is the way you were hoping this mechanism might work might not be biological, it might be human behavioral, right? That seeing a patient on lower FiO2 might make you more likely to do an SBT, more likely to extubate a patient, so your number of ventilator-free days could be greater, not because of a biological effect of oxygen, but because of the effect on the personnel. So that was one thing, and the inverse was something we really wanted to be careful about, right? Was what about the higher group or the intermediate group if they were on? We really had to be thoughtful not to ensure that we were getting every patient to an SAT, SBT as quickly as possible to make sure there were no differences between the groups introduced by the trial. So our SAT and SBT protocols are those from the ABC trial that was led by Wes Ely's group out of our ICU, and we did modify those for this trial to basically say all of the criteria are the same, except almost no matter how much FiO2 or PEEP you're on, we're going to do an SAT and SBT each day if you don't meet the other safety exclusions. So take the one element that was being studied by this trial out of the picture to ensure that patients weren't being artificially delayed in any way getting an SAT and SBT. And we recorded the time to SBT and all of the details of each SBT and didn't see any differences between groups in time to SAT, time to SBT, time to extubation, et cetera.
Thanks.
Chris, thanks very much. I better come in here. Time is moving on. We need to get on to our panel discussion. I'll reintroduce our panel. Angelique de Man, who was the Chief Investigator for O2 ICU from Amsterdam, Bodil Steen Rasmussen, Chief Investigator for Hot ICU from Aalborg in Denmark, Gilles Capelier from Brescon in France, who is the Chief Investigator for LOCO2, and Victoria Cornelius from Imperial College London, our expert statistician and methodologist. Bodil, I'll start with you. Your thoughts initially on the pilot trial.
Thank you, Rob. First of all, I want to congratulate you, Matt, and your team for doing this excellent study and a nice presentation today. And also, I want to thank Paul for this great editorial, and you got around many of the questions that I had. But I will start with a comment. I think what we definitely have learned with all the prior trial and this trial is that we can target oxygenation as clinicians, as nurses. We didn't knew that 10 years ago, but we can definitely do that. And also, we have learned that a lot of patients do not need oxygen in the intensive care unit. And I think that is an important message. I have a question regarding your COPD patients. We in the Hot ICU had problems with recruiting COPD patients because our clinicians said that if we target the high oxygenation target, we can't wean the patient from the ventilator. In this trial, you include patients consecutively with no informed consent. And what did you learn about these COPD patients during your study? Do you have clinicians who don't want to target the high targets in COPD patients? And did you have any problems with weaning the patients from the ventilator in the high target group?
But I think that's a great question. COPD is one example, and there are maybe several others where there are some some data in other settings and some fixed beliefs that can make it challenging. I think one of the things that we have to emphasize is a nice part of our design was that clinicians always had the ability to modify the target at any point, patients and families too, were there to be a situation in which they felt a better target. So if there were a patient in the higher target group who had COPD and the clinician felt, I think this is going to get in the way of weaning off the ventilator, they filled out this one-page form and changed the target to what they wanted to. And we recorded all of that. So for those looking through it in the background table, S12 has each of those modifications. And as you might expect, there were a handful of them for COPD in the higher target group. So I'm looking at it now, and there were 8 instances in the higher target group, 1 in the intermediate target group. So clinicians had that flexibility, but that means the majority of cases, they didn't feel they needed to exercise it. So I think when we look at patients, the majority of patients with COPD were able to complete the trial without any challenges and without clinicians feeling like they needed to modify the target.
And you kept the patient in the designated target during the analysis.
That's right. So everything you see about our separation between groups, et cetera, includes all of the patients and is biased towards noise and null. So I think all patients' data after these patients with COPD who it's modified, et cetera, they're all in the analysis, yes.
Okay.
Super. Angelique, maybe we'll hear your thoughts.
Yes, well, first of all, I would like to congratulate Matthew with this great trial. I think it was an enormous achievement what you did. So congratulations, and I think you also had a great separation between groups. One thing I noticed was that actually the achieved PaO2 levels in your groups were quite low, and especially in the high oxygenation group, the median PaO2 values were between 81 and 95. So the high group was actually quite normoxic. When you look, for example, at the landmark trial of Evert de Jonge, the large observational study investigating the association between PaO2 and mortality, the nadir of this curve was actually around 17. So a PaO2 value of 17, so more or less 130 millimeters of mercury. So I think, what do you think about that? Actually, you did not really achieve high oxygenation levels in the high oxygenation group. So maybe you may have missed the nadir of mortality.
So I think that's a great question about PaO2, and the data relevant to this for those looking through things are in table S10 of the supplement. And what I would highlight first, PaO2 values are assessed intermittently, selectively for a small fraction of patients in this environment. So only 1 in 4 patients had a PaO2 value assessed on any given day. So I would point out that those are not an average random sampling of patients. It's almost certainly patients who are more hypoxemic, regardless of which group they were in. So I don't think the average PaO2 values in that 1/4 of patients should be taken to be describe the distribution of PaO2 values, because patients who had an SpO2 of 99 or 100% are almost certainly not getting an arterial blood gas. They're not likely to be in that 1/4 of patients who have a PaO2 measured. So I think that's probably the biggest caution I would have, is that I think unlike settings in which these are measured every 6 hours or measured routinely, these are indicated PaO2 values and probably don't give you a sense of the full description. And they're definitely selected for patients who are sicker with worse lung injury. So
well, that might be the case, but your achieved SpO2 level was also lower than you aimed for. It was between 96 and 97, more close to 97. And we had an article several years ago investigating the association between SpO2 and PaO2 values. And then we saw that at SpO2 levels of 97, you had hyperoxic values around 20-30%, but at 98, you had hyperoxic values defined as above 100 in around 80%. So with 97, you will not have had many values around 100, I guess.
Yeah, I think your second point is a good one, which is to say that the pilot trial did not intend to have a group that contained significant hyperoxia as a deliberate treatment. So unlike HYPERS 2S or something, we can comment very little on values that are above that range that was set. Now, of the SpO2 values in pilot, the proportion of them that were in 99 or 100, so place where you're almost certainly your underlying PaO2 may represent hyperoxia, was more than a third. So of all the values in the higher target group, at least a third of the time is at 99 or 100%. So I think I'd have to look back and see what that's like in other trials, but that's pilot didn't deliberately expose anybody to hyperoxemia, but that those SpO2 values of 99 to 100% are within the range where hyperoxemia could be occurring, and are almost certainly patients who were not having arterial blood gases measured for those to show up in the PaO2 distribution.
Mm-hmm.
Fantastic. Victoria, I'll come to you in just a second. We'll change track and look at the statistics in just a moment. But Gilles, hopefully you've been in with us and you've managed to catch enough of the conversation so far. Could I have your first thoughts and your impressions on pilot, please?
Yeah, thanks a lot. Finally, I found the study quite interesting and fascinating. And Paul and the other speakers have already produced a high number of comments and questions. So I have little less to say, but finally, LOCO2 was an ARDS target study. And I didn't find in your study as many patients as I was expected to find. And I have two questions regarding this subpopulation. Someone already mentioned that according to the PIP FiO2 table, I would have expected to have difference, to find difference. And it's something I don't really catch with your results. And I suppose that perhaps there's not so many ARDS patients, meaning that finally they didn't require high FiO2 to get this PIP level. In our study where we did find difference between both groups, and we recently finished a study demonstrating at least that targeting different SpO2 induced different FiO2 and different PIP level and ventilation strategy. So I'd like to hear your comments on that. And perhaps the second question, more than 95% of our patients in LOCO2 were sepsis 3 patients. And it's something I look like the Pierre Asfar study, the HYPER 2S study, looking at high and low value. And I'd like you to comment on the number of, you say sepsis and septic shock in your presentation. Just wondering how many patients did have the sepsis 3 criteria. And do you think it will change some view on your results in this subgroup of patients? Anyway, thanks. It's a very fascinating study.
Thank you so much. I'll take each of those in turn. So I think you've highlighted one of the challenges of associated with early intervention. So these patients in pilot were enrolled often in the emergency department, and often their first mechanically ventilated breath, so the first time they were ever receiving PEEP, they were already receiving the assigned SpO2 target. And so we don't have a measure of baseline ARDS or severity of illness in the way that a trial that enrolls patients already on a ventilator and then randomizes them does. So I think that's an inherent weakness of this design that we should acknowledge is we can't. So the patients who had bilateral infiltrates at the time of availability and met the Berlin criteria for ARDS, those are presented, but most patients, many patients with ARDS probably do not meet those full diagnostic criteria down in the emergency department, but over the next 24 or 48 hours do in the ICU. So you'll see in our baseline table, there are not there's a much lower than you might expect number of patients with ARDS. But then in the supplement, by several days in, we see more cases of ARDS having developed. So I think that I offer that caution about assuming that the baseline assessment of ARDS occurring on the first mechanically ventilated breath in the ED is fully capturing the portion of patients who are actually experiencing ARDS. I think your second half of that question about ARDS was that one of the things that we were cognizant of was that PEEP and proning are two therapies for ARDS that might improve outcomes and might be more likely in a higher target group. I think you all saw this in LOCO 2. And so I think our pilot is probably not the best place to examine that question because we didn't experience a difference in PEEP or proning or inhaled flow and or other things. But I think a challenge for setting oxygen targets is what if the setting a higher oxygen target encourages clinicians to deliver other therapies that improve outcomes if PEEP and proning are in that category. So I think pilot doesn't have a lot to say about that because those weren't different here, but I think your question raised is a great one, is what's the difference between what is driven by the oxygen and what is driven by differences in co-interventions. And I think your last point was on sepsis or septic shock. So we use the sepsis 3 criteria. So the about 250 patients or 300 patients almost per group that are described in Table 1, and in the subgroup are patients who met the sepsis 3 criteria. I think we are looking at that sepsis subgroup in a secondary paper that we'll submit shortly here. So I think we're very interested in that group for physiologic reasons. The oxygenation might have different effects, so I think we hope to follow that up more closely.
Thanks, Matt. Victoria, sorry, come to you last, but as Paul raised some great points already about the design of this trial, I'm sure you'd like to comment more on it.
Yeah, thanks, Paul. It touched on all the important points in his editorial. And yeah, congratulations on a brilliant trial that must have been so difficult to deliver during COVID as well. Just to comment, yeah, on the design generally, as in it's the first time I've come across a design like this. It's quite brave, and I'm not surprised because it's very powerful design. You've got one cluster, and then we're not randomizing individuals, not randomizing clusters, but you're randomizing time periods. So and that gets repeated over time. You managed to do that 18 times, so it's incredible. So when I'm thinking about that kind of design, I think there's two things that really stuck out to me. One is about, you know, when we think about crossovers, we always think about washout periods. And I think one question is, you had a washout period towards the end of one period, and whether or not that would have been better straddling 2 periods. Would that have helped increase the separation in your group? And the second sort of point I wanted to make, because I know everybody's, you know, this is clearly made good separation between the groups, that you achieved that more than the other trials. But if I go back to your research question, it wasn't as much as you had intended to. You know, you really haven't targeted that lower level. And I think if, you know, I know you've shown the means and the precision around the means over time, but you haven't really, a better way to look at that is to actually look at the distributions of what you achieved. And so there's quite a lot of overlap between your through groups there. So I think there's a sort of a second question around whether, you know, is that contamination? Is it just not possible to get people to target that lower level? And is that still a question you want to answer?
Thank you. So those are both great questions. The first of which was talking about the design of the washout periods. And I think are still methodologic questions that are completely open in this area. And so I think whether to include washouts of what duration and at the beginning, end, or overlapping a period change are still unanswered questions. I think because we chose that washout length such that knowing the average duration of mechanical ventilation, we would have very few patients experience crossover. So that the crossover in trial group assignment. So that was where that duration came from. And I think I don't know the answer of how, as Paul mentioned, the logistics of crossing over are really paramount. And so I think the ability to start the new intervention on a single day was, for the respiratory therapists who are actually delivering this as part of their protocol, was really helpful. And we haven't looked at compliance in those first couple of days of a new period to make a judgment about whether having the washout overlie the period would have been beneficial in achieving better compliance. So I'm interested in that, but I don't know the answer to that. The second piece of it, I think, was the question about what you target versus what you achieve. And I think I think when you look at trials of a target, the way that would be applied in practice is targeting that same target. That is to say that I think if there's a patient on room air and that their SAT is higher than the target, in clinical practice, you're not going to change their oxygen to be below room air to achieve that target in the same way that a patient in a trial of vasopressors who's above the target and on no vasopressors. So I think the question of what was the effect of these targets can be answered by a trial that faithfully adheres to those targets, even if it doesn't achieve them because of limits in what changes the therapy you would make to achieve those targets, if that makes sense. So targeting an oxygen level of 90% and turning down the FiO2 every time you can is testing what the effect of that oxygen target is on outcomes, even if a third of the time you're on room air and you can't turn down the oxygen to achieve the target. So I think Pilot and many of the other trials tested the target, even though the targets can't be universally achieved. I think the only thing you could do to achieve the targets universally is to enroll patients for whom they're always on some amount of supplemental oxygen, and it's always less than 100%, right? That only if you avoided the two extremes where it's unmodifiable could you actually ever achieve the set target 100% of the time. And so because every patient's oxygen requirements fluctuate over time, I think for this question, that's probably not doable, but you certainly could enroll a little bit sicker patient population and spend less time near that FiO2 threshold of 0.21, or enroll a less sick population and spend less time near the 1.0 if you wanted your target and your achieve to be a little closer.
Thanks, Matt. Bodil, to come back to you, I imagine clinicians will read this paper, listen to this live stream, and they'll work through their own internal checklist, and they'll come to internal validity following on from the points Matt has just made, and they'll say target SATs 90, 94, 98, we got 94, 95, 97. But it sounds to me like the intention was there to do this as well as possible, and therefore it is highly internally valid. What would you say?
I want to ask Matt a question, because I think it's very important. You find the number of severe hypoxemia was the same in each of the three groups. I think this is very interesting. But also, I wonder whether the gas exchange impairment was not as high as, for instance, in the hot ICU trial, because we have hypoxemic respiratory failure in our population. So you have a majority of patients who have probably no gas exchange impairment, meaning that you can't lower the SpO2 down to 88 to 892 because you have them on positive mechanical ventilation, and then you will increase the oxygenation in the blood just because of the positive positive pressure ventilation. So isn't that a problem that you have many patients who have no gas exchange impairment, and you will not be possible to achieve a level of 88 to 92 due to that?
Yeah, so that's a great question, and it asks about the level of gas exchange impairment and therefore the required FiO2 to hit each of these three targets. And I think patients' gas exchange impairment changes over time, and in fact, most frequently improves over time. And you can see in the figure 1, which shows our separation between groups, our starting FiO2 in the higher target group is 60% and is almost 50% in the lower target group. So that's, I think it was 0.7 in hot ICU, and so I don't think that's dramatically I think hot ICU targeted acute hypoxemic respiratory failure patients specifically. I think that's also the majority who's in pilot, that this is a lot of sepsis, pneumonia, and a respiratory ICU. And so those FiO2 values, I don't think, I think there are important trials of oxygen targets in brain injury, in cardiac arrest, where patients have no oxygenation deficit, but the free radical questions and questions about hyperoxemia are still important. So it's still an important question, even if your lungs are functioning perfectly. But I think the amounts of FiO2 required at enrollment in pilot are substantial and are not markedly different than other trials. And I think that reflects a patient population who start with some degree of gas exchange impairment, although that certainly gets better over time to the point that many patients are able to come off oxygen as they improve.
Yes, and I think the most important here is that you managed to separate the three groups. There's clearly separation, and as Paul mentioned, the most clearest separation between groups in any of the other trials. So what the clinicians can use here is that it's feasible to target several different levels, low, intermediate, and high. But we still need a lot of answers to questions regarding the heterogeneity of the patients. And as Paul mentioned, you have patients with home ventilation who are on oxygen at home with chronic mechanical ventilation. We never see these patients in Denmark as well. So it's not a homogeneous population you have, and I will be looking very much forward to see the result of Paul's MegaROX trial, because we there will have some questions of these different population we see in the ICU. So I think we can target it, we can target low without increasing the risk of severe hypoxemia, and I think that's a very important message from your trial. And we have to individualize our oxygen therapy in the ICU, and we have some pieces to the puzzles, but we, as clinicians, we have to decide for each individual patient, where do we believe, based on the evidence we have now, that this particular patient's target should be during the ICU stay.
Thanks, Bodil. We only have a couple of minutes. We're actually over time. So, Angelique, is there anything else you would like to ask Matt, or any other comments you'd like to make?
Well, I think one of the points which have already been mentioned was that oxygen exposure is not restricted to the time of mechanical ventilation. So I saw in your manuscript that patients could have been admitted to the ICU for almost 48 hours. And in this time, they may have received non-invasive mechanical ventilation or high-flow nasal oxygen therapy. And I think these patients can also develop severe hyperoxia or hypoxia. And now you have restricted the time to mechanical ventilation, and you could start immediately after initiation of mechanical ventilation, which is a huge advantage. But I think the other time period is also important. And furthermore, I think your trial adds to the evidence that oxygen therapy in the range between 70 or 150 millimeters of mercury, as was described by Zhao et al. In their meta-analysis, this also adds up that with the less extremes of oxygenation values, you are more or less safe.
Thanks, Angelique. Gilles, a final comment or question from you?
Yeah, I think it's a nice work, at least to reassure our team and saying that, like Paul has said, that probably we can target higher oxygenation that was used to say like the low 90% fairing the risk of high FiO2, at least in the group of patients which has been described by Matthew in his study. I will say that finally this population is quite protected by high FiO2. It's well known that the less injured lungs, the more finally facing high FiO2. I mean, if an injured lung is probably susceptible to high FiO2. So as long as the lung was not so injured, probably it was well tolerating higher FiO2. And in the other end, I mean, as the patient was not that sick, or at least some of this patient, probably low PaO2 was not by itself also toxic. So I think it's interesting at least to say in a general situation that targeting the 96% saturation is probably safe. And we can do that on a regular basis, pending we get the results in some subgroup of patients. So anyway, thanks a lot.
And Victoria, a last comment or question from you, please.
So many. But I just wanted to say, just well done. I think this is a really difficult trial to have done, and to have done, done those repeated things over time, to have that power and to achieve that separation is fantastic. That's all. Yeah.
Thanks very much, Victoria. Paul, you're a man who enjoys a challenging trial design. There have been multiple trials now looking at oxygenation within relatively normal ranges. Do you think there's any appetite for replicating a COAST type trial and pushing the physiological boundaries out into mild and moderate hypoxemia?
Yeah, I don't think there's a strong biological rationale for doing that myself. I guess if we get to the point after the Megarox trial where low looks like it's best, then it might be reasonable to say, well, okay, if low's best is a bit lower, even better. But my sense with where we're going with the literature so far is that it's actually more probable that a bit higher is better. Most of the trials now, particularly the more recent high quality trials have a point estimate in favor of more liberal oxygen. It's a small effect, but there's a signal of benefit from being more liberal there. So I personally don't see that there's a strong biological rationale or a strong signal emerging from the data that would push you towards being hypoxemic, and indeed why it would be a good idea to target abnormally low oxygen is not all that clear to me.
Thanks very much, Paul. Matt, we'll leave the final word with you.
Well, this has really been a joy for me to be able to share our team's years of work here with an audience and panel that are well positioned to appreciate it and where the challenges lie. So thank you all for the discussion and for all of your points. I think I'll end with that thank you and highlighting that we have, as a community, an obligation to examine these treatments that patients are already receiving, already experiencing any risks and benefits of. So if you haven't already and you can, join Paul Young's Megarox trial and whatever the next comparative effectiveness trials are in critical care, so we can be back on these calls in the future answering these questions and knowing which of these really common treatments are best for patients.
Fantastic. Well said, Matt. Angelique, Bodil, Victoria, Gilles, Paul, and Matt, thank you all so much. Matt and the rest of the Pragmatic Critical Care group in the United States of America, thanks so much for giving us the honor of hosting the results tonight. That is it from Belfast and our friends around the world. We hope you enjoyed this. The paper is live online on the New England Journal of Medicine website. Please do go and read it. From Belfast, good night.